Dear ladies and gentlemen, Desmoid-type fibromatosis is a rare and not very well understood neoplastic lesion of a soft tissue. We would like to explain the specific features of the disease in this short seminar. The hospital of the University of Munich is centered in the west of the city of Munich, the capital of Bavaria. Orthopedic Oncology is part of the Orthopedic department, highly specialized on the treatment of patients with bone and soft tissue tumors. We perform about 700 to 800 surgical procedures per year. This seminar is based on the excellent recommendations published by Kaspar et alia of our Desmoid Working Group of the European Organization for Research and Treatment of Cancers of Tissue and Bone Sarcoma Group with patient advocates from Sarcoma Patients Euronet. Desmoid-type fibromatosis is a rare monoclonal fibroblastic proliferation characterized by a variable and often unpredictable clinical cause. The name Desmoid was coined by Müller in Berlin 1838. Although histologically benign, Desmoid-type fibromatosis is locally invasive and associated with a high local recurrence rate, but lacks any metastatic potential. According to the World Health Organization, Desmoid-type fibromatosis is defined as clonal fibroblastic proliferation that arises in the tips of tissues and is characterized by infiltrative growth and a tendency towards local recurrence, but an inability to metastasize. Multiple lesions are seen in about 10% of patients. Considering the variable clinical presentations, the anatomic locations and biological behaviors, an individualized treatment approach is required. Desmoid-type fibromatosis is a distinct rare tumor entity and is seen in about 2 to 5 cases per million of the population per annum. Desmoid-type fibromatosis occurs mainly between the age of 15 and 60 years with a peak age of about 30 years. Although most Desmoid-type fibromatosis occur sporadically, approximately 5 to 10% arise in the context of familial adenomatous polyposis, FAP syndrome. The frequency of APC germline mutation carriers among Desmoid-type fibromatosis patients is higher in a pediatric patient population. An incidence of 3.5 to 32% has been reported in FAP patients. Sporadic Desmoid-type fibromatosis, the most common form, affects young adults, especially females, often related to pregnancy. In older patients, there is no gender preference. Although it may be observed in nearly every part of the body, it often involves the extremities, including the pelvis and the shoulder girdle, also the trunk, mostly the abdominal wall, but may also occur in the abdominal cavity, mostly within the mesentery or the pelvis and the head and neck region. FAP-associated Desmoid-type fibromatosis is predominantly located within the abdomen, has no gender predilection, and its natural history is complicated by previous surgery for FAP. Therefore, in abdominal Desmoid-type fibromatosis, it might be helpful to perform a colonoscopy to exclude signs of polyposis, especially for patients under the age of 40 or with beta-catenin wild-type status. There is a publication which also recommends colonoscopy in extremity-type desmoid tumors in younger patients. There are some reports describing a hormone dependency of a lesion, mainly based on the efficiency of anti-estrogen therapy, but results are, as shown, conflictive. No established or evidence-based approach for the treatment of this lesion is available for today. Therefore, a multidisciplinary and individualized approach is strongly recommended. A careful counseling and a reference center or network is mandatory and should be offered to all patients affected by sporadic Desmoid-type fibromatosis from the time of their diagnosis. When a Desmoid-type fibromatosis is suspected, the patient's management, including the biopsy, outside the reference center or network, should be discouraged, and all patients should be discussed within a multidisciplinary tumor conference. Due to the rarity and long natural history of the disease, the level of evidence is being available for more common tumor types is currently beyond reach for Desmoid-type fibromatosis. There is no published phase 3 randomized clinical study on the treatment of Desmoid-type fibromatosis. There are few phase 2 trials. Most published data are from retrospective case series. A higher level of uncertainty needs to be accepted in Desmoid-type fibromatosis, both for regulatory and for clinical decision making. A stepwise approach to sporadic Desmoid-type fibromatosis, including an initial watch and wait strategy, has recently been proposed jointly by the Italian and the French sarcoma group. A biopsy confirming Desmoid-type fibromatosis diagnosis is mandatory. In most cases, diagnosis of Desmoid-type fibromatosis can be made on core needle biopsies. An incisional biopsy is not needed. But given the rarity of the disease, a diagnosis of Desmoid-type fibromatosis has to be confirmed by an expert soft tissue pathologist. Extra-abdominal Desmoid-type fibromatosis typically arises from the deep fascia or within the muscle tissue, as in this 35-year-old male patients, while the majority of intra-abdominal Desmoid-type fibromatosis occur in association with a small bowel mesentery. On first sight, the lesion frequently appears nodular or as a bulky mass, but tentacle-like spiculated extension with infiltrative growth are regularly found macroscopically or microscopically. You can see them by cutting the tissue. Multifocal appearance is observed in about 10% of the cases and is seen in sporadic Desmoid-type fibromatosis, but FAP should be excluded in all those patients, at least in all those patients. Not uncommonly, Desmoid-type fibromatosis arises at the site of a previous operation or trauma. Microscopically, Desmoid-type fibromatosis consists of spindled fibroblast and myofibroblast oriented in a fascicular pattern with prominent collagenous background. Mildly gapping vessels are evenly distributed within the tumor and myxoid changes may be present. The tumor cells have a poorly defined cell border merging with a collagenous matrix and a nuclear oval with little variation. Differential diagnosis includes scar tissue, upper fibroblastic lesions as nodular fasciitis, solitary fibrous tumor, and sarcomas with spindled morphology. Especially the low-grade fibromyxoid sarcoma must be seen in this context. Specifically, distinction of Desmoid-type fibromatosis recurrence from scar tissue at the site of a previous resection may be difficult, very difficult, and exclusion of fibrosarcoma is of particular relevance in the light of a currently proposed watchful waiting strategy. So if you wait and you wait in a malignant tumor, you are definitely doing harm to the patient. Immunostaining for beta-catenin with nuclear positivity in Desmoid-type fibromatosis is helpful in establishing the diagnosis, while cytoplasmatic positivity has been demonstrated not to be specific for Desmoid-type fibromatosis. Approximately 80% of sporadic desmoid tumors harbor mutations in the beta-catenin gene, leading to nuclear accumulation of beta-catenin protein. To our knowledge, beta-catenin mutations and APC mutations are mutually exclusive in desmoid-type fibromatosis. Thus, the detection of a somatic beta-catenin mutation may help to exclude a syndromal condition. Vice versa, beta-catenin wild-type status in desmoid-type fibromatosis should raise the suspicion for FAP with more extensive diagnostic clinical workup, as for example the colonoscopy. Also, mutations analysis of beta-catenin was recently proposed as a specific diagnostic tool for establishing a diagnosis of Desmoid-type fibromatosis. It is currently not part of a routine diagnostic workup. However, it is strongly encouraged. Different mutations of beta-catenin have been described in fibromatosis, with T41A and S45F being the commonest ones, accounting for about roughly 50% or 25% respectively. While two independent studies reported on an increased risk of recurrence in fibromatosis with S45F mutations, other studies did not observe such a correlation. Ongoing prospective studies will show whether beta-catenin mutation analysis will be useful for the management of different therapeutic regimes. Desmoid-type fibromatosis presents as a deep, poorly limited infiltrative mass. It often consists of several nodules close to each other or more separated, but usually in the same part of the body. However, when lesion is originally detected, magnetic resonance imaging is the main imaging modality for characterization of the disease. So you see the node, you have the nodule, you see the tumor, but you must precisely know how large it is, how much tissue is involved, where are the borders, how is the signal inside the tumor. On MRI, the pattern is very variable. Low signal intensity components on T2-weighted sequences indicate fibrous tissue and are suggestive for a diagnosis. But some high signal is also possible in the same lesion or in other ones. It is very conflictive sometimes. In the rare situation where the patient has several lesions, the signal is often different in each of them. In the same way, contrast enhancement is very variable, sometimes very strong, sometimes absent. Different behaviors are again possible in the same lesion or in different lesions in the same patient. This patient is another example, a 61-year-old male with swelling at the left shoulder. He declined further therapy. You see the large lesion here in the left axilla. And because he declined therapy and he get just observation, we had the chance to follow up a tumor, and he developed a progressive disease. Attempts to link the signal and tumor aggressiveness, especially the high signal and T2, and strong uptake indicating an active lesion, as in this patient, gave poor initial results but deserve a prospective evaluation on a larger number of patients treated by a homogeneous approach. The studies are just too small. To evaluate efficiency of a targeted therapy such as imatinib, the use of positron emissions tomography with FDG PET has been proposed. In a pilot project, 22 Desmoid-type fibromatosis patients were analyzed using FDG PET before imatinib treatment initiation and 4 to 6 weeks after start of treatment. A median decrease in the standardized uptake value of 30% could be demonstrated. The authors concluded that PET may be used as a surrogate marker in order to predict response to therapy early, and that's important, early in the course of treatment, and help to decide whether therapy should be continued. A low signal intensity in T1 sequences, infiltrative pattern and multiplicity are suggestive of the diagnosis. However, histological proof is always needed to rule out other diagnoses such as nodular fasciitis, usually a very superficial lesion, and with edema or a sarcoma with a fibrous component. In particular, the main histological desmoid-type fibromatosis mimic is a myxofibrosarcoma, as told before, which also often has an infiltrative pattern. Before 2000, surgery with negative margins had been considered the standard of care for patients affected by desmoid tumors. Reflecting the same approach to extremity soft tissue sarcomas, where surgery is also the first method of therapy. Due to the very specific infiltrative growth pattern, the resection needed to achieve negative margins in desmoid-type fibromatosis, but that could often be larger for a same-sized sarcoma, leading to potential impairment of function and cosmetic alterations in patients affected by a benign disease. Because of all those tumor parts infiltrating deep into the soft tissues, it's very difficult to get a clear margin in these lesions. Indeed, unlike soft tissue sarcomas, where positive margins are a well-known predictive factor for local failure, the prognostic significance of positive margins after excision of desmoid tumors is in fact minimal, if any. A few large series with more than 100 patients reported a lack of correlation between positive margins and local recurrence. However, other results are contradictory, as impact of margins depends on many factors. So you will find also reports that say clear margins are very important. So this is a very conflicting situation. The lack of concordance has been reported in both directions. So for example, recurrence in spite of negative margins and no recurrence despite positive margins. This observation leads to a reassessment of overall management, and the preservation of function became a high priority. I will show you just some examples. This 80-year-old patient has pain in his left arm since 2 years. You see the lesion at the axillary plexus. The resection was only part, because we could not resect the nerves. We left the nerves untouched and we did radiation therapy. He has a stable disease over now more than 10 years. In this 26-year-old female with a desmoid in the delta muscle, 3 resections, including resection with negative margins, did not prevent recurrence. Imatinib therapy was effective. The pregnancy needed the cessation of imatinib. We have sometimes very young patients where pregnancy is a very important factor. In other patients, one may find an uncomplicated follow-up, as in this 36-year-old female, where all was good and she did not ever have a recurrence. Surgery might even deteriorate the outcome, as in this patient who developed a large recurrence just 4 months after the initial surgery. You see the recurrence large, very, very large. In some cases, as in this 17-year-old female, surgery is only indicated to reduce symptoms as flexion contracture. In this 60-year-old male patient, several resections and radiation therapy controlled the disease with acceptable functional outcome, but not long-lasting healing. In other patients, as the 65-year-old male or this 33-year-old male, you may see an excellent result. You resect the tumor and you see no further recurrence. Our own recurrence-free survival is about 78%. Most recurrences were seen in the first 2 years after surgery. Local recurrence was lesser seen in the primary lesions, as you see here, and younger age proved to be a worsening significant factor. Resection margins did not influence the prognosis at all. Furthermore, some patients experience spontaneous stabilization or occasional regression of their tumors, even after multiple recurrences. Therefore, many investigators proposed to further limit morbidity by considering an initial observation period in all patients, including those with primary tumors, especially when surgery would have resulted in some loss of function. Several recent retrospective series have consistently shown progression-free survival rates of 50% at 5 years for patients managed with a frontline conservative, watchful waiting approach. While these initial observations demonstrate the potential safety of such an approach, it is important to emphasize that these patients remained under close observation, such that no patient was lost to follow-up, and treatment plans could be altered if a tumor progressed. So you have to do repeated MRI investigations. Increase in size was usually mild and occurred in the first 2 years, as also in the surgically treated patient. Spontaneous regressions were also observed in as many as 5 to 10% of cases. There may be sites where regression is more common and observation may be safer, for example in the abdominal wall. Nevertheless, regression has been observed at all sites. Therefore, it is reasonable to consider watchful waiting as an initial step when asymptomatic tumors are located at critical sites as close to nerves or mesentery before undertaking subsequent treatments. When the observational approach fails, surgery is still a valid option. When performed, surgical resection should be aimed at obtaining microscopic negative margins or for function preservation, especially for tumors located in the extremities and the girdles, should always be taken into consideration, and other alternatives, including radiation therapy, as you see, this title here, must be considered when appropriate. Furthermore, a large sporadic or mesenteric retroperitoneal desmoid-type fibromatosis may be treated with surgical resections anyway, just because the size and its possible related symptoms need that. However, this may not always be possible, and the approach should not be too aggressive. Systemic therapy can also be considered in that situation. Therefore, in the absence of biologic prognostic factors capable of predicting the natural history of the disease, don't have them. Watchful waiting is a reasonable approach to minimize overtreatment and unnecessary morbidity in a subset of patients with desmoid-type fibromatosis. Prospective observational studies are presently underway to validate these results and possibly shed more light on the biological background of this very intriguing disease. In patients with progressive, locally advanced extremity desmoid-type tumors, where resection would result in an important functional sacrifice, isolated limb perfusion with tumor necrosis factor alpha and malformant and hyperthermia is an option and seems to be a very effective treatment. Most patients become stable or experience at least a partial response after ILP. I personally remember one case with a large non-resectable progressive tumor in the lower arm in a female professional piano player who kept stable after ILP was done in Berlin. Asymptomatic patients should be carefully watched without active management as suggested by National Comprehensive Cancer Network and European Society for Medical Oncology guidelines. Symptomatic patients with tumor masses that can be operated upon with acceptable morbidity should be offered surgery. In case of wide resections, there is no indication for postoperative radiotherapy. If, however, the margins are not clear, a re-resection should not be routinely considered and patients should be monitored preferentially. Maybe they don't grow. As stated above, in desmoid-type fibromatosis, there is a lack of correlations between positive margins and local recurrence. Hence, adjuvant radiotherapy may be an option for patients operated for recurrent disease, especially if located at critical sites. Note that the average desmoid-type tumor patient is young, very young, with an anticipated life expectancy of decades, and can therefore be preferred subjects of late radiation-induced morbidity, including secondary malignancies. Moreover, intra-abdominal locations are not the best candidates for radiotherapy. You have a bowel, you have a bladder, you have a kidneys, all very sensitive organs that you can possibly harm. In case of patients with symptomatic and progressive disease in whom surgery would result in significant morbidity, both medical therapy and radiotherapy can be considered as single-agent regimes. Radiotherapy at a dose of 56 gray, 28 once daily fractions of 2 grays, has been shown to provide adequate local control in the majority of progressive patients. It works, but there is no statistically significant difference in local control between radiotherapy regimes above or below 56 Gray. But there is a significant increase in late radiation-related morbidity if you give the patients above 56 Grays. So local complete remissions are seen in 14 to 70%, partial remissions and disease stabilizations in 50 to 77%, and local failures and recurrences in 18 to 32% of the cases. However, the risk-benefit ratio must be discussed with every individual patient in the reference centers where the experience is there. For clearly progressing cases where optimal treatment is not standardized, we don't know it exactly, and needs, as always, to be individualized on a multidisciplinary basis. We have different pharmacological options that can be proposed, comprising hormonal therapies such as tamoxifen, non-steroidal anti-inflammatory drugs, low-dose chemotherapy, tyrosine kinase inhibitors such as imatinib, and full-dose chemotherapy using especially anthracycline-based regimes active also in soft tissue sarcomas. To better define the efficacy and the indications of each of these treatments, inclusion of patients in the existing open trials is essential. We fight for every patient. Anti-hormonal agents may be used alone or in combination with non-steroidal anti-inflammatory drugs as first medical treatment, mainly because of their limited toxicity, rare events, and their very low costs. However, the response rate to anti-hormonal therapy and also the non-steroidal anti-inflammatory drugs is rather low. And in those patients who do respond, objective response is only observed after several months of treatment. Therefore, a general recommendation for its use could not be given. When the relevant issue is critical anatomic site in the case of hormonal and non-steroidal anti-inflammatory drugs, therapy failure or for aggressively growing and or symptomatic or even life-threatening Desmoid-type fibromatosis, chemotherapy is advisable. Full-dose chemotherapy using anthracycline-based regimes is characterized by a higher response rate. There is also prospective uncontrolled evidence for the activity of the tyrosine kinase inhibitor imatinib in patients with progressive Desmoid-type fibromatosis. With high rates of stabilization of around 60 to 80%, despite a rather low response rate ranging from 5 to 15%, with a favorable toxicity profile. Nevertheless, the level of evidence remains low because of the absence of randomized clinical trials properly assessing the activity and clinical benefit of imatinib. Currently, sorafenib is being tested in a phase 3 study in the United States of America. In general, it is reasonable to employ the less toxic therapies before the more toxic ones in a stepwise fashion. However, due to the lack of randomized or comparative data, we are not in a situation to propose a definitive order of the existing systemic treatment options. Comparative and randomized studies are highly encouraged in the medical treatment setting to gain more evidence-based data which could help to guide us through the treatment plan. As with other cancer patients, Desmoid-type fibromatosis has in many cases pain, restricted range of movement, and other problems or symptoms which must be controlled. Psychological support, social support, information and rehabilitation must be supported if needed. Depending on the anatomical localization, Desmoid-type fibromatosis is often associated with symptoms of pain and discomfort. However, the pathogenetic mechanisms of pain in this type of tumor are certainly complex and multifactorial and not very well understood up to now. correlation between pain and disease progression is not very good. Some stable Desmoid-type fibromatosis patients may have pain. Some progressive patients may feel nothing, especially no pain, and this can be due to progressive local regional treatments as well. Taken together, pain should be treated independently from the Desmoid-type fibromatosis itself and can be managed normally with medical treatment according to the existing standard, for example the WHO standard. In non-progressive yet very painful Desmoid-type fibromatosis, local and systemic treatments may be considered as options for symptom control, not for controlling the disease, but just for symptom control. A reassessment of the overall management of Desmoid-type fibromatosis has taken place during the last 2 years. In contrast to radical and often very mutilated treatment, the preservation of function and avoiding cosmetic alteration has become a priority in the overall management of this disease. Therefore, the quality of life plays a fundamental role in the therapeutic algorithm of Desmoid-type fibromatosis patients. It should always be in consideration that Desmoid-type fibromatosis is a benign disease and that the quality of life of the patient should be the focus in treatment and decision-making. Taking into account the uncertain behavior of Desmoid-type fibromatosis in the young patient population, it is recommended to offer patients psychological and social support to help them maintain a normal life. Additional support is especially needed during the period of intervention or if pain is a significant problem. Management of Desmoid-type fibromatosis patients in reference centers and networks requires the collaboration with pain control specialists, with physiotherapists and psychological oncologists. Many women present with Desmoid-type fibromatosis have had a recent pregnancy. A recent publication investigated retrospectively as always a possible relationship between the desmoid tumor and pregnancy. 44 women had pregnancy-related Desmoid-type fibromatosis, whereas 48 had a history of Desmoid-type fibromatosis before conception. Initial treatment was resection in 52%, medical therapy in 4%, and watchful waiting in 43%. Post-surgical relapse rate was 13% in the first group, although progression during watchful waiting was 63%. Relapse progression in the second group was 42%. After pregnancy, 46% of the patients underwent the treatment of a Desmoid-type fibromatosis, whereas 54% were managed with watchful waiting. Eventually, only 17% experienced a further progression after treatment. Spontaneous regression occurred in 14%. After further pregnancies, only 27% progressed. The only related obstetric event was one cesarean delivery. The others concluded that pregnancy-related Desmoid-type fibromatosis has a good outcome, that the progression risk during pregnancy is high, but it can be safely managed. Desmoid-type fibromatosis does not increase the obstetric risk, and it should not be a contraindication to future pregnancies. So the presented consensus algorithm you see in here has been proposed on the basis of a roundtable meeting on the 8th of May 2014 in Frankfurt, Germany, bringing together experts from the sarcoma community and the European Organization for Research and Treatment of Cancer, the soft tissue and bone sarcoma group, with patient advocates from Sarcoma Patients Unit. The primary aim of the meeting was to develop a consensus approach based on the professionals and the patient's expertise and available evidence that is sometimes conflicting. Patient advocacy groups are helpful to reinforce the explanations given by health professionals and to avoid some misunderstanding, especially if we propose a wait-and-see policy. So you have a tumor, you want to get it rid, And the doctor says, no, we just wait. Diagnosis of a sporadic Desmoid-type fibromatosis should be based on histology gained from a needle core biopsy. We prefer needle core biopsies and not open incisional biopsies. When a patient with a sporadic Desmoid-type fibromatosis is first evaluated, we do not know at which time point of a natural history of his personal disease we are observing this very special patient. Therefore, there is clear consensus that a conservative watch and wait strategy should be the frontline approach to newly diagnosed patients, irrespective of existing pain or other clinical symptoms. Supportive care should be applied in an optimal way, that's clear, in this situation. This observational strategy offers a way to understand the behavior of the disease and tailor the next treatment steps. Due to the natural history of the disease, the time interval for a watch and wait approach could be 1 to 2 years. Very close follow-up is required, of course. For tumors located at critical sites such as the head and the neck and the pelvis or intra-abdominal, because local regional growth may become a problematic or even life-threatening event in these cases. In general, when this conservative strategy is chosen, patients should be closely followed up, preferably using contrast-enhanced MRI. The first clinical and radiological re-evaluation should be done within 4 to 8 weeks, then every 3 months in the first year, then 6 monthly up to the 5th year, and then yearly thereafter. In the case of stabilization or regression, the watch and wait strategy should be continued. In the case of progression, alternative treatments, as we had discussed it above, should be discussed with the patient. However, the exact definition of progression is difficult. In most cases, the strategy is switched to a definitive treatment in the case of an objective tumor size progression in multiple, for example, 3 consecutive images. So you do 3 consecutive MRIs, and if every MRI says the tumor is larger than in the MRI before, you have a clear progression. Further steps should be tailored according to the anatomical tumor location and the patient age and comorbidities as described in the algorithm. You see it here. In the case of a progression of Desmoid-type fibromatosis localized at the abdominal wall, hormonal therapy might be an option, which is usually very well tolerated and does not cause any major adverse events. A more definitive strategy, of course, is surgical resection. There was strong consensus in the group that radiotherapy doesn't play a role in this clinical setting. For intra-abdominal Desmoid-type fibromatosis, it was clearly agreed that surgery remains the main treatment in the case of progression if the tumor is surgically treatable. For retroperitoneal or pelvic Desmoid-type fibromatosis, medical therapy should be the first therapeutic option. Different systemic treatment options such as tyrosine kinase inhibitors, low-dose or even full-dose chemotherapy may be chosen. However, due to the lack of randomized or comparative data, it is absolutely not possible to propose a definitive order of the existing systemic treatment options. So we prefer a stepwise approach, starting from one therapy with a few side effects. That's in our personal sense very reasonable. In the case of further progression or relapse, medical therapy or surgery or radiotherapy would be an option with a tendency towards surgery if the tumor is resectable, with preservation of function. That is important, with preservation of function. For Desmoid-type fibromatosis of the extremity the girdles or the chest wall, the decision for the type of the initial active treatment should be guided by the expected post-operative functional impairment or morbidity. As this can be highly subjective, every patient is different. Post-operative consequences should be clearly discussed with the patient on a very individual basis. If a lesion is not involving major vessels or nerves, an observational strategy should be continued. If a lesion threatens to involve major vessels or nerves, take into account the patient with a lesion in the axilla. Surgical resection should not necessarily be considered the first option. The alternative to surgical resections would be medical therapy. Other alternatives for a limb tumor include the isolated limb perfusion with tumor necrosis factor alpha and melphalan, the radiotherapy that is very commonly available, or the chemotherapy plus hyperthermia if available. If feasible and available, the isolated limb perfusion can be considered for tumors located in the extremities. This loco-regional modality may be especially advisable in multifocal disease if you have several tumor nodes alongside one extremities, at the hand or the foot, for example. No resection of a remnant tumor is usually proposed if you do a R2 resection. In the case of further progression or relapse, definitive surgery could then be proposed. In the case of positive surgical margins in critical situations, adjuvant radiotherapy must be considered. For critical anatomical locations, especially at the head and neck or intrathoracic sites, there is very clear consensus that medical therapy would be the first treatment choice. In the case of further progression or relapse, radiotherapy should then be discussed in these highly radiosensitive structures. If surgery is considered as an option, additional radiotherapy should always be considered to minimize the risk of local relapse. The message of this seminar is very clear. Desmoid-type fibromatosis is a lesion which requires a highly interdisciplinary paced approach, starting from watch and wait, with doing nothing, just observation, till major local therapies, surgery, radiotherapy or systemic treatment with different or less aggressive drug regimes. Please do not hesitate to read the basis of the seminar, the paper published by Kaspar et alia from Mannheim of the Desmoid Working Group of the European Organization for Research and Treatment of Cancer, the Soft Tissue and Bone Sarcoma Group of the EURTC, with patient advocates from Sarcoma Patients Euronet by yourself. Read it. If you are interested in gaining more information, visit us at www.orthopediconcology.org. Thank you very much for your patience and your attendance. See you next time.